Good morning, everyone, and welcome to day 2 of our meeting, day 3 actually, but welcome to the INC Keynote address. This year we made a couple of changes in the overall process for this presentation. We moved this to prime time. Yay! Clap. When I do this, clap. No, I'm kidding. Anyway. We also we added an award this year. Really, it's the first year, it's the inaugural DEI Abstract Award. And this is an award that is given to an author of an abstract which explores diversity, equity, and inclusion in neurocritical care in a variety of ways, in patient care, or education, or professional development. And so it's my distinct pleasure to introduce to you the inaugural winner of the DEI Abstract Award, Kara Melmed from NYU Grossman School of Medicine. Please come up. Her abstract is titled Neighborhood Socioeconomic Status and is associated with discharge mortality after intracerebral hemorrhage. Dr. Melmed.
Thank you so much. Thank you. Thank you so much. Good morning, everyone. Thank you for having me today and for honoring me with this award, and thank you to Dr. Kumar as well. I'm delighted to speak to you today about our research on the impact of neighborhood socioeconomic status on withdrawal of life-sustaining therapies after intracerebral hemorrhage. So we know that mortality is associated with withdrawal of life-sustaining therapy after ICH. We know that social determinants of health can be associated with mortality. So we sought to determine how is withdrawal of life-sustaining therapy after ICH impacted by social determinants of health. We performed a retrospective study of patients with ICH over 3 tertiary care hospitals between 2017 and 2022 using the Get With The Guidelines database and automated EMR data retrieval. We found race and ethnicity as entered into the EMR on admission. We obtained occupation, marital status, and religion as self-reported. Zip codes were linked to median household income from the 2021 United States Census American Community Survey, and insurance was reported as Medicare, Medicaid, dual, private, or no insurance, or self-pay. Dual eligible beneficiaries is a group with unique health disparities, and thus was coded as its own group. Our primary outcome was withdrawal of life-sustaining therapy. This was defined as either documentation of conversation and agreement by the surrogate of the patient for withdrawal of all life-sustaining therapy, any palliative extubation, or any admission to hospice. Our secondary outcomes were mortality, poor discharge modified Rankin score as defined by 4 to 6, and discharge disposition. We also obtained comorbidities, NIH stroke scale, and ICH score were used as markers of admission clinical severity, and hospital length of stay and ventilator days were used as markers of illness severity. We compared all of our covariates using May and Whitney U-test and chi-square test, and then performed multivariable analysis for each social determinant of health category using all covariates with p greater than 0.1, and then using backwards elimination. We performed receiver operating curves for median household income within the zip code to predict withdrawal of life-sustaining therapy, and then performed additional analyses in patients who lived in zip codes in which the median household income was less than the national median. We identified almost 12,000 patients, 868 of whom had ICH. The median age was 67, and 43% were female. This graph demonstrates the discharge disposition for all patients broken down by social determinant of health. Most patients went home, 28% went to acute rehab, and 20% went to a SNF or LTAC. Mortality occurred in 17% of patients, and of these, actually 84% were due to withdrawal of life-sustaining therapy. And I'll now go through these one by one. Older age was associated with the withdrawal of life-sustaining therapy, with a higher median age for patients who did undergo withdrawal of life-sustaining therapy. The preferred language in our cohort was English in 72% of patients, and although there was no difference in withdrawal of life-sustaining therapy or modified Rankin score on discharge, we did find that in neighborhoods that had lower median household income, English preference was associated with lower withdrawal of life-sustaining therapy. Race and ethnicity breakdown in our cohort was 16% Hispanic or Latino ethnicity, 18% Asian, and 17% Black non-Hispanic. This graph shows patients that were discharged alive in blue, patients who had hospital mortality in orange, with the proportion of patients who had withdrawal of life-sustaining therapy in light green. There was a significant difference in patients that were Black non-Hispanic, with lower rates of withdrawal of life-sustaining therapy and mortality in this group. This finding was also replicated in patients that were from low median household incomes areas only, but we also found that Hispanic or Latino patients in these areas had higher rates of withdrawal of life-sustaining therapy. The majority of our cohort was Christian. 20% reported no religion or atheism, and 12% of our patients were Jewish. Christian patients had more withdrawal of life-sustaining therapy, primarily driven by the Catholic patients who also had more withdrawal of life-sustaining therapy and higher mortality. Patients with no religion or atheism had less, and after adjusting for age, ICH score, length of stay, and ventilator days, Jewish patients had less withdrawal of life-sustaining therapy with an adjusted odds ratio of 0.15. Widowed patients, 12% of our cohort, had more withdrawal of life-sustaining therapy. Employed patients, which was 27% of our cohort, had less withdrawal of life-sustaining therapy, and patients with private insurance also had less. When we looked at patients who had withdrawal of life-sustaining therapy, patients had higher median household income of $88,000. The percentage of households with an income greater than $200,000 was greater, and the patients who had a median household income of less than $70,000 was less in patients who had withdrawal of life-sustaining therapy. This is the receiver operating curve. Median household income is shown in blue, ICH score in green, and age in red for reference, and the AUC was 0.6. After adjustment for age, ICH score, hospital length of stay, and ventilator days, this finding remains significant with an adjusted odds ratio for patients with median household income by zip code and withdrawal of life-sustaining therapy of 1.88 and a 95% confidence interval of 1.29 to 2.74. We also found that female gender was associated with less in this analysis. So, mortality discrepancies exist in this population. An exploration into the relationship between social determinants of health and withdrawal of life-sustaining therapy can allow us to understand why. Here we showed that patients with higher neighborhood socioeconomic status have higher rates of withdrawal of life-sustaining therapy and thus higher mortality. Although neurology-trained neurointensivists conducted the goals of care discussions, and this training background is typically associated with a good ability to predict poor outcome, we can't exclude the possibility that unconscious or institutional bias might have led to the findings when we think about how we discuss end-of-life care. It's thus imperative that when we conduct goals of care discussion, we should think about using a race and socioeconomic conscious framework that can also give credence to the holistic well-being of the patient, to familial duties, concern for caregiver burden, and for different practices and needs for spirituality of the patient and their family. Exploration of core values is paramount, and while financial considerations should not dictate life or death decisions, it's important to recognize the cost of care after ICH, particularly for families who are living in neighborhoods with inequitable resources. So in conclusion, social determinants of health are associated with withdrawal of life-sustaining therapy and mortality, and further research is required to investigate the relationship between mortality and withdrawal of life-sustaining therapy and the structural and social environments that can influence systemic health and hemorrhagic stroke in various neighborhoods. Understanding these associations is crucial for comprehending the broader implications and factors influencing health outcomes in different populations. And the association between mortality in areas with higher median household income suggests that social determinants of health have important repercussions for the care and the management of patients with ICH. So considering how to tailor our perspective and our language might be one step towards creating a more equitable approach to goals of care discussions after ICH. Thank you very much for your attention today, and thank you to all of my mentors who helped with this project.
Thank you, Dr. Melmed, and congratulations on your accomplishment. Good morning, everyone. I'm Tommy Thomas, and I'm excited and proud, and it's my pleasure to introduce our esteemed keynote speaker today, Dr. Manisha Kumar. Dr. Kumar is a neurointensivist and an accomplished clinical researcher. Her area of expertise is in coagulation derangements associated with severe brain injury. She is a professor of neurology, neurosurgery, anesthesiology, and critical care, the vice chair of quality for the Department of Neurology, and the director of the Neuro-ICU at the Hospital of the University of Pennsylvania. She is the immediate past chair of the Penn Forum for Gender Equity and a leader in the Neurology Department's Inclusion, Diversity, and Anti-Racism Efforts Committee. She is completing her tenure here on both the NCS Board of Directors and Executive Committee, and served as the board liaison to the Inclusion and Neurocritical Care Committee. Please join me in welcoming her as she presents the impact of changing landscapes of patient autonomy on healthcare and disparities in neurocritical care.
Good morning. Thank you, Tommy, for that warm introduction, and thank you to the INC Committee for inviting me to give this talk, and thank you to Dr. Vespa and the Annual Meeting Committee for the same. I am very excited to present to you my talk entitled The Impact of the Changing Landscape of Patient Autonomy on Healthcare Disparities in Neurocritical Care. Beyond the horizon is the theme for this year's meeting, and I think it's an apt descriptor of this talk, because the session will focus on some of the current and future legal landscape, what it might mean for the practice of neurocritical care. So I have no relevant disclosures, but I do have some caveats. I'm not a lawyer, I'm not an ethicist, but I am an academic physician and concerned citizen who believes that healthcare providers need to understand the implications of the current climate on patient care, clinical practice, and medical education. Although we will touch on complex subjects, the focus of the talk will narrowly be on healthcare disparities and the intersection with neurocritical care. I am truly honored to share my thoughts and my personal opinions with you today, and I share them in the spirit of academic discourse. You may disagree with what I say or how I say it, and that is welcome, because the goal here is to stimulate conversation and promote engagement with our colleagues. A smaller caveat, one common problem in this area of research and discourse is the lack of standard nomenclature and categorization regarding race, ethnicity, and gender. I use whatever the language is in the studies that I'm presenting, and I've included the sources and reference for your interest. So today we're going to discuss three seemingly unrelated legal issues in the United States: the Supreme Court decision on affirmative action, Students for Fair Admission versus Harvard and UNC, the Supreme Court case Dobbs v. Jackson Women's Health Organization about abortion to women's health reproductive care, and the Uniform Determination of Death Act, which underpins brain death determination in the United States. I will argue that these three cases have the potential to worsen healthcare disparities significantly and affect our practice of neurocritical care. So in brief, I'm going to make the case that the loss of affirmative action will worsen healthcare disparities due to reduced representation in the provider workforce and will affect performance of clinical teams in ICUs, research labs, and academic departments. I will posit that the loss of access to abortion will worsen healthcare disparities due to reduced prenatal care access, will infringe on shared decision-making in neurocritical care, and sets precedent for criminalization of evidence-based practice. Lastly, I will offer that the same arguments used to overturn Roe v. Wade may impact the ongoing revision of the Uniform Determination of Death Act, which would have impact on both neurocritical care practice and organ transplantation. But first, we'll talk about healthcare disparities. So what are healthcare disparities? The CDC defines health disparities as preventable differences in the burden of disease, injury, violence, or in opportunities to achieve optimal health experienced by socially disadvantaged populations. That's a mouthful. Simply put, healthcare disparities are differences in health outcomes among groups of people and their causes. 20 years ago, the National Academy of Medicine published Unequal Treatment, shedding light on inequities of care by race. They found that racial and ethnic disparities in healthcare exist, and because they're associated with worse outcomes, are unacceptable. So why do healthcare disparities exist? They exist due to a myriad of societal factors ranging from economic to environmental to educational ones. Healthcare disparities are assessed by certain metrics, including mortality, life expectancy, healthcare expenditure, and functional limitations. So what evidence do we have for these disparities? I will offer you these examples. In a study of over 80,000 patients from a healthcare claims database, Black and Hispanic patients were significantly less likely to undergo coronary angiography after ST elevation MI. And even when angiography was performed, they were less likely to receive an intervention when indicated. Data from the NIH indicate that Black people are 4 times more likely to have kidney failure than whites, and infant mortality is twice that for Black neonates than white. The COVID-19 pandemic exacerbated long-standing disparities in life expectancy. Life expectancy dropped from 79 to 76 years for white people, 75 to 71 for Black people, and 72 to 65 years for American Indian or Alaskan natives. And we don't have to go past our own ICUs to see these disparities. Black patients are nearly twice as likely to die from stroke as white patients, and AIAN people are more likely than any other racial group to die from traumatic brain injury, and they're also less likely to receive follow-up care and rehabilitation after TBI. Living in a disadvantaged neighborhood has been linked to a number of healthcare outcomes, including higher rates of diabetes, cardiovascular disease, increased utilization of health services, and earlier death. The Area Deprivation Index is a measure by the Health Resources and Services Administration that allows for rankings of neighborhoods by socioeconomic status disadvantage and includes factors such as income, education, employment, and housing quality. Dr. Amy Kind at the University of Wisconsin has created an interactive map of the ADI with resolution down to the US Census-defined block. On this map, blue is the least disadvantaged, whereas crimson is the most disadvantaged. And in this study from colleagues at Penn, the authors compared disadvantage to race and found that disadvantaged groups are comprised of larger shares of people from racial and ethnic minorities. Racial groups are arranged on this chart from left to right by their share of the overall population. So the gray columns represent race. The black columns show the proportions of each racial group falling under the most disadvantaged quartile using the ADI. And you can appreciate that Black and AIAN people comprise an outsized proportion of disadvantage when compared to their population share. In addition to societal and systemic factors of healthcare disparities, it should be noted that healthcare disparities may be exacerbated by healthcare providers ourselves. The National Academy report states racial and ethnic minorities tend to receive lower quality healthcare than non-minorities, even when access-related factors are controlled for. They found evidence that stereotyping, biases, and uncertainty on the part of healthcare providers can all contribute to unequal treatment. And this was exemplified by a study published in the New England Journal in 1999. In this study, actors were employed to read from the same script describing symptoms of chest pain. Simulated patients allowed the researchers to control for any differences in presentation and factors, including insurance status and EKG findings. They interviewed physicians on their assessments of patients and prescribed treatment. And what they found was that assumptions made appeared to influence action. They found significant difference in physician assumptions in that females seemed to over-report their symptoms, or they felt that Black males were the least likely to comply with treatment. And this translated into differences in physician action. Males were 40%, had a greater odds of referral for cardiac cath compared to women, and whites had a 40% greater odds of referral for cardiac cath compared to Black simulated patients. In a more recent study from 2020 of medical students, researchers found that white medical students believed that Black patients have thicker skin and fewer nerve endings, and as a result, they recommended less pain medication to fictional patients. Disparities in care reflect long-held false beliefs about marginalized groups, and unfortunately, there are quite a few examples such as this in the literature. Now that we've established the existence of healthcare disparities, let's talk about the implications of the Supreme Court ruling on affirmative action. So I hope to make the case that affirmative action increases diversity. Diversity is associated with better outcomes. The Supreme Court ruling threatens diversity in medicine, and therefore this ruling is likely to lead to worse healthcare outcomes. So diversity has been shown to improve performance across many disciplines, from finance to business to science. And diversity has been shown to improve the delivery of care and improve healthcare outcomes. So not only has diversity been shown to enhance performance, but it enhances performance in financial investments, ethical decision-making, and I mentioned science. This is a particularly illustrative example by the McKinsey Group. It was a report of hundreds of multinational companies, including Fortune 500 companies. They assessed the diversity of their executive boards and compared those with the most diversity to those with the least diversity. And they compared it against returns on equity and margins on earnings before interest and taxes. They compared the top quartile in the dark blue bar to the bottom quartile in the light blue bar, and they demonstrated that companies with more diverse boards were associated with an over 50% return on equity and an increase in EBIT of about 14%. It was more striking for companies in the United States, where the return on equity was 95% and the earnings before interest and taxes, or EBIT, was 58%. In this article from Critical Care Medicine last year, the authors wrote, "The advantages of diversity may be particularly pronounced in academic medicine, where new clinicians are trained and the majority of research is performed. The presence of leaders who are underrepresented minorities benefits both trainees and early career faculty, as they can see role models congruent with their own identity. In the research setting, having a diverse group of scientists increases the likelihood of producing higher quality science." But how does diversity improve performance? It does so through cognitive diversity. And by that I mean it increases creativity and the search for new information and novel perspectives. Said another way, it avoids groupthink. So what is the proof? Well, I mentioned before that mortality for Black neonates was twice that of white neonates. Well, this study found that if there's racial concordance between infants and physicians, infant mortality is halved. And for those of you who attended the opening keynote, Dr. Bohorak mentioned similar data about gender concordance and cardiovascular outcomes in women. In this study, Black representation in the primary care workforce was associated with a reduction in all-cause mortality for Black people and even an increase in life expectancy. It was an assessment of over 1,600 US counties. And in a mixed effects model, a 10% increase in Black provider representation was associated with a higher life expectancy of more than 30 days. In this review from Johns Hopkins, underrepresented minority physicians were more likely to provide primary care and serve areas with provider shortages. They were also more likely to care for the disadvantaged. And minority physicians essentially were providing care in that crimson area on the ADI map that I mentioned before. So does affirmative action improve diversity? The simple answer is yes. In 1961, President John F. Kennedy signed an executive order which compelled government contractors to take affirmative action to realize the national goal of non-discrimination. Between 1966 and 1976, the total number of Black students quadrupled in colleges and universities, from 280,000 to over 1 million. 20 years later, the state of California enacted a ban of affirmative action, and within 2 years, there was a 40% drop in Black and Latinx enrollment at UCLA and UC Berkeley. And students that comprised that drop attended less competitive schools, had worse long-term job prospects, were less likely to attend graduate school or to enter a STEM field. So in companion cases, students for fair admissions versus Harvard College and students for fair admissions versus UNC, the US Supreme Court held that Harvard and UNC's admissions programs violate the Equal Protection Clause of the 14th Amendment and ruled to significantly restrict race-conscious admissions practice in undergraduate education. The majority opinion wrote that the admissions process failed to comply with the twin commands of the Equal Protection Clause. One, that race must never be used as a negative, and two, that it should never operate as a stereotype. And thus we transitioned from race-conscious admissions to race-neutral ones. But both the AAMC and the American Nurses Association were quick to recognize that although the ruling pertained to undergraduate admissions, this would have grave repercussions in medicine and healthcare. The AAMC writes that the decision demonstrates a lack of understanding of the critical benefits of race and ethnic diversity in educational settings and a failure to recognize the urgent need to address health inequities in our country. The ANA statement boldly writes that the decision signals the continuation of systemic and structural racism, which has inflicted generational trauma in terms of lack of access and academic professional advancement, and that the decision will impact the necessary pipeline for diversity within the profession to provide culturally competent and equitable healthcare. Another argument for the benefits of diversity comes from the majority opinion itself, which stated that race-conscious admissions are permissible in some instances, such as the military. It should be noted that in the dissenting opinion, Justice Sotomayor writes that the same arguments made for the military apply to healthcare. This study, performed in response to the potential loss of affirmative action in a case in 2015, took data from the AAMC database to formulate projections on what would happen to uninsured and underinsured patients by the year 2025 with reduced diversity in medical schools. And what they found was that reductions in diversity would cause reductions in primary care providers, such that we would be unable to care for 1.25 million Medicaid patients. On the other hand, if there was representative diversity in medical school, for just a 3-year period, we could increase the number of providers to cover 750,000 uninsured patients. So in summary, healthcare disparities are likely to worsen in part due to underrepresented minority representation or lack of underrepresented minority representation in the provider workforce. And for you, you should know that diversity improves outcomes. So whatever team you're working on, diversity makes it better. And encouraging and safeguarding diversity is paramount in medical education, research and science, and clinical practice. Now let's transition to women's reproductive health. The case I intend to make is that the Dobbs v. Jackson ruling will worsen healthcare disparities and have significant implications on the practice of neurocritical care. US maternal and fetal health outcomes are worse than in other industrialized nations. This discrepancy is magnified in minority and minoritized populations. And the Dobbs v. Jackson ruling will worsen US maternal mortality and significantly restrict access to prenatal care, which will only make the situation worse. And this will likely increase pregnancy-related neurologic complications. This ruling compromises shared decision-making between providers and patients, and it sets a precedent for criminalization of evidence-based practice. I will argue that this ruling addresses the legal definition of life, which may impact the legal definition of death, significantly brain death, with the impending revision of the Uniform Determination of Death Act. So in the Dobbs v. Jackson Supreme Court case, the opinion was held that the Constitution does not confer a right to abortion, Roe and Casey are overruled, and that the authority to regulate abortion is returned to the people and their elected representatives, which basically means that jurisdiction reverts to the state level. So data from the CDC demonstrate that US maternal mortality is 3 to 12-fold higher than for other industrialized nations. This graph depicts deaths per 100,000 live births, and you can see that the US fares worse than our counterparts in Europe or Australia and New Zealand. What's worse is that maternal mortality is getting worse. It's not static, it's worsening. So in this chart, you can see it's death per 100,000 live births on the y-axis, and on the x-axis, it's years. So the blue bar there is 2018, green is 2019, and so on. And you can see the rise. This rise is disproportionately borne by Black and brown women. And Hispanic women saw the largest increase in mortality over a one-year period. It increased 54% between 2020 and 2021. Although it disproportionately affects Black and brown women, it should be noted that it cuts across all levels of socioeconomic status, and adolescents have the highest risk of complication. On the right of the slide, you see a picture of Tori Bowie, an Olympic gold medalist for sprinting, who is in peak physical health, who died at the age of 32 in June from complications of childbirth. Twice as many Black and Hispanic women obtained care at healthcare clinics. These clinics were largely financed by procedural revenue from performing abortions, and the loss of this revenue has resulted in closure of these clinics, reducing access to care. In this chart by the Kaiser Family Foundation on the right, you see that the dark blue bars are the fractions of people who receive care at clinics. And you can see that there's an increased fraction with increasing poverty, lack of insurance, and marginalized race. Anti-abortion legislation obviously reduces access to abortion in those states, but it also reduces access to prenatal care even in states where it's legal. This is largely due from displaced persons seeking care in states where it's legal, but that there's confusion, even in states where it's legal, about what care they can provide. This briefing, entitled Human Rights Crisis, was sent to the UN earlier this year, and it outlines the consequences of these laws on the 22 million women and adolescents in states with restricted access to care. It outlines interviews with physicians from the University of Michigan, from the University of California at San Francisco, who have not been able to provide care given ectopic pregnancies, for patients with incomplete miscarriages, because of some confusions with the law. They've had to wait till patients get septic before intervening, and they even interview hematologists and oncologists about delays in cancer care for patients who may be pregnant. In the state of Texas, there were an additional 10,000 live births in the 9 months since restrictions were in place. But it's unclear whether there are the increased resources to accommodate these increased births and whether there'll be healthcare disparities for those children. It's also unclear who will provide the increased need for obstetrical care. And it should be pointed out that 44% of OBGYN residency programs are in states that may or have banned abortion. Residents choose to train where they can get access to training around abortion to learn those techniques. And we all know that trainees stay in the areas in which they're training. And so this might exacerbate care deserts exactly in the areas where there's increased need. And if you look at the map of where abortion is restricted on top, with the dark red color being the most restricted, it looks very similar to the ADI map that I presented earlier. And so actually this is being borne out. So in a study looking at access to care between states where abortion is still legal and where abortion is not, what they found is that there are fewer maternity care providers in states where abortion is not accessible or less accessible. There's higher rates of maternal mortality, higher rates of infant death, higher overall death rates for women of reproductive age, and greater racial inequities across the healthcare system. And so how is this a neurocritical care issue, Mona? Well, this was a patient that came in through our ED last week when I was on service. It was a 20-year-old pregnant woman who arrived to the ED with this massive cerebellar hemorrhage and brainstem compression. You can't appreciate the hydrocephalus, but it was there. She had no brainstem reflexes, and she was 30 weeks pregnant. Ultrasound demonstrated that it was actually a twin gestation, and no family was present initially. What would you do? How would you proceed? Would it be different if she wasn't 30 weeks gestation, if she was 6 weeks? What are the rules in your state? Do you know? The potential for compromise of patient-provider autonomy here is huge. And so reduced access to abortion care reduces access to all care in some states for some women. Reduced access results in increased medical and neurological complications. And there's a shift of focus from the patient, the mother, to the fetus even before gestational viability. And so for you, the provider-patient relationship may be compromised and even criminalized. Variability of laws by state lead to confusions in healthcare, and this contributes significantly to moral distress and burnout. And so now we'll turn our attention to brain death determination. The Uniform Determination of Death Act is the basis of state laws and statutes regarding brain death and relies upon a distinction between life and death based on neurologic criteria. It also relies on adherence to accepted medical standards. However, brain death has been controversial since inception. There have been increasing legal challenges that suggest there's less confidence by the public. Implementation, unfortunately, of the UDDA seems to vary state to state, but there are efforts underway to revise the UDDA and standardize practice nationally. It should be pointed out that the debate over abortion also relies on making a distinction between life and death. And Dobbs v. Jackson criminalizes adherence to accepted medical standards in obstetrics. And what might that mean for neurocritical care? The Dobbs decision has decentralized abortion legislation, reverting jurisdiction to the states, making it more complicated for us to practice. And so it's reasonable to speculate that the Dobbs decision might impact the concept of brain death. And so we're trying to centralize legislation, and we're trying to clarify issues of patient and physician autonomy. And obviously, if this does come to fruition, there may be implications for healthcare disparities in organ transplantation. So the Uniform Determination of Death Act was drafted by the Uniform Law Commission back in 1980, and it's been a model statute for 40 years. It reads, an individual who has sustained either irreversible cessation of circulatory and respiratory function or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. A determination of death must be made in accordance with accepted medical standards. However, many are calling for the law to be updated. Verbiage in the law is not aligned with medical practice, and there's been erosion of public trust. Specific verbiage that seems to have controversy are all functions of the entire brain, accepted medical standards, and irreversibility. There has been a call to update the law by some in this room, and they propose a transition from an anatomic approach to a functional approach. Rather than require irreversible cessation of all functions of the entire brain, including the brainstem, the UDDA should require brain injury leading to a permanent loss of A, the capacity for consciousness, B, the ability to breathe spontaneously, and C, brainstem reflexes. This would better align the medical practice with the law and improve the confidence of providers in the reliability of medical standards. It also would create transparency with patients and the public about what is assessed by these standards. So why should we revise it now? So I mentioned that there's a lack of trust by the public and a lack of uniformity in its implementation. You can be dead in one state, but not dead in another. And the accepted medical guidelines are not standard. In this Nature report from last month, they wrote that these language discrepancies mean that guidelines put out by organizations such as the AAN, outlining what physicians should test for when declaring brain death, don't line up with the UDDA. And as Dr. Greer presented yesterday, the variability of brain death policies in the US is unacceptably high. So taken together, this lack of standardization could put providers in legal jeopardy. And so in addition to clarifying the definition of brain death, the Uniform Law Commission is determining whether consent is required for assessment and is considering bracketed text which serves as optional recommendations for state laws. But again, this variability causes confusion and contradicts the goals of standardization, similar to where we are in the post-Dobbs era. And in that Nature review, they wrote, as the Uniform Law Commission revision process has progressed, clinicians who were once eager to address these issues have become increasingly worried. Fueling their fears is a rising tide of political polarization and mistrust of scientific expertise. Some clinicians, following the ULC discussions, say that the idea of brain death itself is facing its greatest challenge since the conception in the 1960s. The outcome could have serious implications for ICUs across the US and might affect the availability of vital organs for transplant. Some physicians fear the revision of the UDDA in this current social climate, and it should be pointed out that the Uniform Law Commission is made up of 15 attorneys. And in that Nature paper, they write that one of the commissioners serves as the general counsel for anti-abortion organization, the National Right to Life Committee. He says that he publicly supported the UDDA in the 80s, but has changed his mind in the past few years and no longer thinks that brain death constitutes biological death. He now argues that even if a person has no chance of recovery, they still have rights. And so what do we do with certain populations like brain death in pregnant patients? Fortunately, the AAN has a position paper on this, and they write that if a brain dead patient is pregnant, ethical analysis should focus on the welfare of the fetus. But they also write that the AAN endorses requests by lawful surrogates and loved ones to withdraw organ-sustaining technology if a fetus has not reached a viable gestational age. But this may now be defined by the state you live in and not the relationship you have with patients and their surrogates. As with other cases, changes in determination of brain death could exacerbate disparities in organ transplantation. So I mentioned that Black patients are 4 times more likely to have kidney disease than whites. but only half are likely to receive a kidney transplant. Black patients are less likely to receive an organ from a living donor, which has better outcomes. And disparities in organ transplantation exist in all domains, from referral to evaluation, transplantation, and follow-up. And so in terms of brain death determination, revised definition of brain death will impact organ transplantation, but also the provider-patient relationship may be compromised, and I fear criminalized, similar to what might happen with OBGYNs. Variability of laws by states leads to confusion in healthcare, and healthcare organizations are relatively conservative. They're risk-averse, and they don't want to be on the wrong side of the law. This is going to contribute to moral distress and burnout. So in summary, the current legal landscape has direct bearing on medical practice in general and neurocritical care practice in particular. Diversity improves patient outcomes and teamwork, so plans to safeguard diversity is critical to ensuring it in academic medicine. The impact of restricted abortion extends beyond women's reproductive health. It's a health equity, shared decision-making, and autonomy issue, and will impact neurologic complications of childbirth. The same controversies and complications in restricted access to reproductive care may extend to brain death determination, and it might exacerbate disparities in organ transplantation. Now, I don't want to end this talk on such doom and gloom, so I feel like we have to talk about what can we do to make this better. So regarding affirmative action, we can set diversity as a priority. We can consider distance traveled instead of race for pipelines and programs. We can employ a holistic review of applicants using structured interviews and evaluations to minimize implicit bias. We can increase recruitment and retention of URM faculty because diversity begets diversity. We can diversify research labs, and we can ensure to include more research with underrepresented patients. And there are even plans to improve editorial boards and the diversity of science. I think it's incumbent upon us to look at social determinants of health, like Dr. Melmed did, in our research to make sure we're providing equitable care. We should work with hospital administrators to clarify practices and processes to best prepare for severely brain-injured women, pregnant women, in advance of clinical catastrophes. We should work locally to define when it may be appropriate by local laws to intervene on a mother's behalf before it gets to be too late. We should work with our ethics teams to obtain guidance with complicated and challenging cases that we know will arise. In terms of brain death determination, we need to advocate for a uniform policy for brain death determination within the United States. We should ensure training programs, like the one NCS has, for physicians who determine brain death, as well as the one that's done by the Gift of Life Foundation through virtual reality. We should make sure to credential physicians in brain death determination regardless of specialty, and to ensure compliance with medical standards for brain death. We should increase research that enhances the accuracy of brain death determination and improve professional and public education regarding brain death. A sincere and heartfelt thank you to the INC and Annual Meeting Committee and to my family at Penn Medicine. Thank you. I think if there are any questions, they're supposed to go through the app. All right.
See if this is what. Oh, good morning. Thank you for your wonderful talk. I was wondering, one of your points you had talked about was race neutrality as a concept, and I was curious your thoughts and opinions on the sentence that is often still in people's notes about 47-year-old male, African-American male, and whether or not that race should be in that first sentence when we present and think and conceptualize a patient?
That's a great question, and I honestly haven't thought a lot about that, so I don't know, but I think that we have to account for social determinants of health as part of past medical history. I think it's pretty critical that we understand all of those things. Whether race alone is enough, I'm not sure, but I think that it's important for us to account for those things as we talk about outcomes and care. Thank you. Dr. Greer.
Great talk, Mona. Thank you so much for sharing that. I've had the, pleasure of serving as an observer on the ULC for the UDDA revision, and it's been a pretty horrific process, I'll be honest with you. And I think it really reflects the polarization in our country right now, that you see opinions that really were considered fringe in the past that have now come to the forefront. And it seems like the sides just aren't listening to each other. Just like we see on a national level, we see it now in our own backyard with the revision, which I think has grave consequences. Is there a way that we can meet in the middle? I mean, I can't think of one, but maybe you can because you're smarter than me, but we need some solutions here.
Agree. No, I was going to kick that back to you because I think that I think this is the concern. I mean, I really think that they're very similar conversations that we're going to be having. What's happened with abortion access, I think, is the same as what's going to happen to brain death determination, and I think that there is cause to be concerned. It's hard because I think it has to be standardized. I think we have to do that. I think we have to do this 100% right 100% of the time, and we're not there yet. But I'm nervous that in this moment, the attempts to revise it could backfire. Dr. Vespa.
Great, Mona. We don't have any questions yet in the chat, so people that want to ask questions, we have a question coming up.
I had a quick question about the case. Like, what happened? What was the outcome?
So the patient went into labor, so she had an emergent C-section, and then because she couldn't get a suboccipital cranie with her pregnant belly, she went for a decompression after. She regained some brainstem reflexes after neurosurgery, and eventually her family made her comfort, but the two infants are healthy.
I had a question over here.
Yes.
I think you might also generate a slide for your future presentation of this talk that talks about attitudes within the patient and family community about brain death and withdrawal of life-saving treatment, and how that affects the rates of organ transplantation and the donor waiting list, because the racial and ethnic attitudes about all of those issues, as well as the data you had about the race and ethnicity of the providers that are interacting with the patients and families around brain death determination and around organ donation, and the well-justified suspicion that patients and families have toward the medical community that are grounded in the past history of race disparities. And so it all sort of is intersecting and tied together. So I think you can't talk about the revisions to the UDDA without talking about those issues as well.
No, absolutely, and I had a couple slides, but I didn't like the graphics, so I left it out. But I work really closely with our organ procurement organization, or OPO, and actually have data on how many recipients receive organs from brain dead donors and how many donate, and the disparities there. And that was the point around, Black patients who have kidney failure, they are less likely to get living donors, and so they only get, they make the vast majority of organ recipients from deceased donors. And so, I think that it's important, and so one of the last points was we have to have a conversation explaining those things but also keeping it separate, because we don't want it to appear that, you know, the medical establishment is defining death so that we can, you know, so there has to be a line, but it also needs to be made clear. And so that's why I think we really need to be transparent about how we're doing this so that the public can trust us. I think public trust is a major concern here on both sides. Hi, Nick.
Hey, Mona, thanks for having the courage to give that talk. Dr. Shutter recently put together a map of neurocritical care training programs, and not surprisingly, it overlays almost perfectly with where we don't have deprivation in that map. So we're not equitably covering the country with neurocritical care. How do we prioritize this as a society going forward?
That's a fantastic question, Nick. You know, I think we talk a lot about, you know, kind of global inequities and things like that, but we don't talk about like how the inequities are in our own country. We don't talk about access to rural care and things like that as we should, although I saw a couple posters on that enlarged by Dave Cedar. So I think that we should be mindful, and we should maybe try to promote education in those areas, but I think that's a much bigger conversation that we need to have.
Hey there, this is Rohan. I thought the talk was excellent. Thank you for highlighting these issues. One thing that seems to be the case with the Supreme Court recently is a move towards states deciding for themselves and state legislatures. And in some cases, things that our society might, or other medical societies might put out as guidelines might become illegal in certain states. Is there an obligation for medical societies to have guidelines that are legal in every single state? Are there thoughts that we have to start tailoring our guidelines to, you know, reflect the laws in different states from a practical basis? And, you know, we put doctors in a very funny situation when guidelines say one thing and the law says something else. So I just wanted to see your thoughts. I know you mentioned you weren't a lawyer, but I would just like your thoughts on that.
No, you know, it's interesting because I think even our ethics committee has been thinking about these types of things. You know, what is our responsibility as physicians, and how can we speak out? But what is? I mean, do we have a singular voice? Sometimes yes, sometimes no. But I think that that's exactly the situation. I think we're going to be in legal jeopardy because the rules governing our practice are going to change, and they're not being defined by providers. So I'm concerned that there's going to be these inconsistencies and disparities in guidance, and and that we as providers are going to get stuck in the middle and potentially, you know, held criminally liable.
So I think a lot of what I'm Verena Borwinkle, I'm from North Carolina. What you're talking about has far-reaching consequences for half of the humans on Earth and their health. And so when medical students are making decisions about what field to go into, they look at the society pressures. So like, for example, yesterday in North Carolina, a young OBGYN was shot and killed in the parking lot on her way out of work. And myself, I used to be an OBGYN resident, and I switched to pediatric neurocritical care because of the controversies around the issues that we're talking about. And I thought I would be somewhat protected from those. And here yet I find myself again at the forefront of thinking about them just as much as I would have in that field. So what can we do to think about how to protect our doctors and protect our flow of doctors into those fields that promote the health of half of the humans on Earth?
Marina, this is a question that keeps me up at night for sure. And like you, I actually matched in obstetrics. I intended to do the same thing and realized that in neurocritical care, I would take care of those high-risk obstetrical patients that I wouldn't have taken care of if I was doing OB. You know, the thing I'm concerned about is that and more, right? I mean, who are the people in medicine? They're largely women. There's 54% of medical students are women. I think 86% or more are nurses. When it comes to the face of medicine, these issues become personal, and those are women of childbearing age. Who are the people in our medical societies? Like when we think about diversity, where are those people coming from? I think that, you know, the Dobbs decision is going to impact decision-making for women, you know, across the country. And I think it's going to be a real challenge. I mean, we already know there's a shortage of nursing. But if these, you know, decisions impact our daily lives, there's going to be a dearth of women in the workforce. You know, we'll see what happens with some of the upcoming legal decisions as well. And I think that, like, you know, workplace violence in medicine has been a big concern that's not really paid as much attention as it needs to be. So I think there's a perfect storm coming. I hate to be so doom and gloom, but I do think that we have to be concerned and we have to take care of one another and we have to be, you know, unified. Dr. Geringer.
I applaud your energy, enthusiasm, and dedication to this really scary topic. I think I agree with you. We live in scary times. I did, though, being a data-driven kind of person, want to circle back a little bit to one issue, which was the transplantation question. As a member of our OPO board for about 20 years, I was particularly interested in looking at, we looked at racial distribution of recipients. And while it's correct that for living donors, the rate favors whites, actually transplantation from brain dead or DCD donors favors African Americans. So this is the disparity that actually is working in the other direction. So this is a really complex issue, and we just need to be careful in terms of where we focus our attentions and make sure we have the picture right. Now, I'm not saying that you know, it's not that there is actually favoring of African Americans. Is probably driven by the rate of kidney disease among the populations. But I don't want people to walk away, because I sort of looked at what you said and I said, oh, are you saying that kidney transplantation favors whites? And that's really, as a whole, not the case.
I did not. What I thought I said was exactly what you said.
Yeah, well, you said only for living directed donors.
Right. So, yeah. But the outcomes for living directed donors are better than for deceased donors. And I think that if deceased donor availability or if organs from deceased donors availability goes down, that will preferentially impact Black patients, specifically with renal transplants.
Right, sure.
Right.
If
that's all.
Deceased donors go down,
right.
then they will be negatively impacted.
Yes, yeah. that was the point. Thank you. Okay, last question, Dr. Cho.
Oh, thank you, Mona. First, I just want to say thank you for leading our voice in this, and this is such a difficult topic, and it has so much, and thank you for just summarizing it so well. As I was sitting in the audience, I just kept thinking, why isn't everybody hearing this? My trainees should hear this, my faculty, med students, and maybe students beyond, because as you said, we need to have a conversation. We may not have solutions, and as Dave has said, you know, no one is agreeing for a very long time, but what are things that we can do, individual people here, that can help at least promote that conversation? You know, like if we walk out of here today, what is the one or two things that we could do to maybe help in this?
Invite me to give grand rounds at your institution.
Vote. Vote, vote, vote. Okay? Register your friends to vote. That is one way we can advocate.
Okay. So thanks, everyone. Please put your questions and comments also in the app. Please fill out the survey in the app. Unfortunately, we have to end this session because we have another session starting at 9:15. Thank you for coming this morning. Thank you, Dr. Kumar, for an exceptional talk. Thanks to you, Dr. Melmed. Have a great meeting, everyone.